Attentive monitoring of the patient continues after the procedure. Certain conditions need to be met before the patient may be safely transferred from the procedure area to a recovery area. The first condition to be met is to ascertain that the patient is able to maintain a patent airway with intact reflexes, including swallowing, coughing, and gagging.
Okay. You need to cough a little bit. Please sit up a little more. Okay, good.
The patient should also be responsive to verbal and tactile stimuli as appropriate. The third condition is that the patient's vital signs are stable with satisfactory oxygen saturation.
The reason for showing you this slide with a patient with a pink elephant hanging over his head is ideally recovery from a sedating event is not just sleeping it off. It's as much a part of the entire process as anything, with its own phase of documentation, guideline satisfaction, and patient preparation for transfer to the next level of care. During recovery from sedation, a Aldrete scoring system is used to document the patient's status. The Aldrete system scores 5 levels of activity on a 0 to 2 score. A perfect score is 10. That is spontaneous activity, respiration, consciousness, circulation, and color. Respiration is quantitated by the respiratory rate and depth, and also by pulse oximetry measurement, the oxygen saturation. The patient is observed for a minute of 30 minutes after the procedure. If antagonist drugs, for instance naloxone or flumazenil, have been used, the patient should be observed for a minimum of 1 hour after the procedure to watch for resedation. It's important to understand that the use of reversal agents should not be routine. There's no free lunch when you use a reversal drug. It's very important to titrate these medications to the desired effect. Narcan or naloxone should be given in doses of 0.1 to 0.2 milligrams. This drug has a profound anti-analgesic effect and can provoke an acute abstinence syndrome. People have been known to develop acute pulmonary edema as a consequence of overuse of naloxone. Flumazenil should be given in doses of 0.2 to 1 milligram. This drug must be given in divided doses and slowly because it can provoke seizures. Antilirium or physostigmine is rarely used today in doses of 0.5 to 1 milligram to antagonize the effects of scopolamine specifically, but it too can provoke a cholinergic crisis.
Certain conditions must be met prior to the patient being discharged from the hospital. These conditions include the patient being fully awake with an Aldrete score of 8 or better. The patient is adequately hydrated. When appropriate to the patient's condition, the patient should be able to walk unassisted. A responsible adult escort should accompany the patient. The patient is advised regarding aftercare with both written and verbal instructions. The responsible attending physician should write the discharge order and also write a discharge note including patient status. A nurse may also discharge the patient providing these criteria are met. Regardless of who discharges the patient, standard institutional ambulatory care protocols should be employed regarding follow-up and care of post-discharge complications.